So the headlines is, do not use thrombolysis thrombectomy to treat DVT at all. That's actually the headline. The major problem, and that's been what we've been saying over the last year, the major problem of that trial was that they included two large groups. So iliofemoral DVT and femoral popliteal DVT. And the femoral popliteal DVT, as we know, do not really respond well on thrombolysis thrombectomy, right? So when you do that subgroup analysis, it's getting positive, right? If you include the entire group like they did, it's going to be negative. So you really have to separate those two groups. Furthermore, what they did is actually a binary evaluation of the disease. So it means either you have PTS or you don't, right? With a cutoff of 5 on the Villalta scale. And we're not going to go into the Villalta scale because there's always a lot of problems with that as well. I mean, a lot of discussion, it's not been published, etc., etc. But if we say, okay, we have a cutoff very arbitrary at 5, Villalta 5, and you don't have PTS below 5 and you do have PTS above 5, then it's negative. But if you have a continuous scale, then you see on every timeline in the study that it is positive. So, and that's exactly the problem with a randomized controlled trial that has been designed in the early 2000s, right? And has not been able to learn from all the knowledge that we acquired over the last 10, 20 years. So, and that's actually the major problem. So headlines, do not treat it. Do we agree on different levels? Absolutely not. Well, my practice is not really affected by the ATTRACT at all, I must say. So first of all, you need to see what is your practice like before ATTRACT, okay? So our practice was like this. We were treating iliofemoral DVT, not femoral popliteal DVT, based upon the data that was already out there, Susan Kahn, the Venus Registry, very good data. We said, okay, femoral popliteal DVT is not really affecting a patient that much, creating a PTS. So we're treating iliofemoral DVT that is above the level of the common femoral vein. What else did we do? We had always good imaging beforehand, so MR venography, not in the study. It has to do with a US study, MR venography not being that available in the US or too expensive. So we could select the patients on basis on really important factors. Let's say we were only treating very fresh clots. We were not treating acute and chronics, stuff like that. So MR venography we did, and it's very important to select the right patients. So what else did we do? We went for maximum thrombus removal, right? Maximum thrombus removal is extremely important. You have to take as much out as possible. The studies are out there. The more thrombus you remove, the less likely it is to get PTS. Multiple studies showing that. They did not do that in ATTRACT, right? They used a very suboptimal screening modality, just angiography in a way in one direction, and estimated how much thrombus has been removed. I think that especially with IVUS, endovascular ultrasound, that makes a huge difference. And we were using already endovascular ultrasound, not as much as I think now, based also a little bit on the trial and thinking about it, as you should use. So that means that maybe if you want to think about, okay, what did the trial actually achieve in my practice? Use IVUS in all the cases, and not just in the cases that I think that I should use it. So all the cases. So that's actually how ATTRACT affected my practice, but not really directly by the outcome. Well, that's a little bit difficult because what you do not want to do is get another RCT and dig an even bigger hole, if you will, right? So we started out with a randomized controlled trial that was positive back in the days. Then the Kevin trial, it's a randomized controlled trial, beautiful trial, was positive. Then the ATTRACT trial came, and it was a negative trial and got the most attention. So now everybody's focused on, the next trial. That trial, if we want to, from my perspective, that has to be very, very positive to stop the discussion, right? So what do we need? Include everything that we've learned. So what have we learned? Do not enter or let patients enter with femoral popliteal DVT. Make very sure that we find all the underlying obstructions causing the DVT and treat them well. And treat very fresh clot. So there's some techniques to find that out. A problem will be that to include acute and chronics, old clot, let's say older than 3 weeks. So you have to be very, very keen on selecting the right patients.